Hi guys, welcome back. The topic that we're going to discuss now is one of the commonest non-communicable diseases in the world, that is hypertension. In fact, 45% of the world population, that's what CMDT 2022 says, 45% of the world population suffers from hypertension. So if I just extrapolate the data, I can say that out of every two people that you will meet, one person is either having hypertension, is not aware of it, or will develop hypertension in future. So obviously the pharmaceutical companies will obviously be smiling at this kind of an information because they're gonna make money. But you can understand from the mankind's perspective, this disease is a slow killer. So what we will do here is first identify some cutoffs. We'll also talk about when should you be starting treatment in a patient. But for that, we need to first observe what is the fluctuation of blood pressure in a normal person. And you will always notice that all of us have a nocturnal dip. The blood pressure of you and me is least in early morning hours, something in the range of about 10% decrease over whatever is the baseline value. And that baseline value is dependent on the race and the build of an individual. Blacks are more predisposed to hypertension. So you notice that in COVID-19, in the first wave in New York, in America, most of the time the deaths that occurred and we were reading about were mainly of blacks, and they were suffering from, most of the people who died, it's not economic disparity. It was hypertension and diabetes mellitus, which were comorbid in this particular race that I said, which contributed to a higher percentage of deaths. Now, when you will compare the blood pressure tracing, I'm talking about a ABPM, that is an ambulatory blood pressure monitoring 24 hours for a hypertensive patient. The first thing that you will notice will be a development of loss of a nocturnal dip. So this is rather one of the early features from the exam perspective. If it says, if you are going to check out the ambulatory BP recording of a hypertensive patient versus a normotensive person, what is the early finding that you will get? Your answer would be loss of nocturnal dip is an early feature that can be identified. And over and above this, you will also notice that the fluctuations in the green curve that I have shown, the magnitude of fluctuations that I've shown in the green curve are relatively bigger in size as compared to the one in red, which is relatively finer. The importance of this is that there can be systolic blood pressure elevation. I agree, systolic blood pressure elevation will cause target organ damage. It will cause left ventricular hypertrophy, subendocardial ischemia, retinal hemorrhage, and all those things that we're going to discuss. But the fluctuations of the blood pressure, I'm not talking about an absolute value. I'm saying if there's going to be variation in the systolic blood pressure, then the incidence of cardiovascular mortality will increase. This, guys, is a silent killer. And if we are going to initiate good control, if you effectively communicate to your patient the importance of compliance, good control of hypertension will definitely reduce the spending in our GDP with respect to at least this particular disease. In fact, studies have shown that if you do effective good blood pressure control, then the incidence of acute coronary syndrome per se decreases by a huge 25%. What I'm saying is, nationally speaking, the incidence of chances of development of MI will be substantially lower. Similarly, the CNS complications will also reduce the incidence of ischemic stroke. Make no mistake, hypertensive people not only can have a hemorrhagic stroke, but they can even have a ischemic stroke as well. Ischemic stroke is more common as compared to hemorrhagic stroke. So if a question opens up by saying hypertensive patient and is having CNS events, don't think or be biased towards hemorrhagic. It could be ischemic as well. But if you are going to be initiating good treatment in a patient and he's obviously compliant, you can decrease these values by huge 30%. Then would be heart failure. That's anyway a disaster because the management of acute decompensated congestive heart failure is really difficult, as you would have seen in your coronary units. We can decrease the incidence of heart failure by as much as 50%, half. So the amount of spending will definitely reduce and the health of the nation will also improve. So hypertension per se, as I said, is a silent killer, and you can reduce all those target organ damages that could be occurring. And now the question in your mind and obviously the patient's mind would be that it's okay to look at this curve, but can you identify a particular value? When would you say normotensive? When would you say hypertensive? So we're going to talk about cutoffs here. And if let me say a non-medico family member of yours says what should be the optimal blood pressure. So though Harrison says that it is dependent on the race and a build of an individual, optimal blood pressure values are defined as not less than 120/80, not 120/80. optimal blood pressure values are less than 117 by 75 millimeter of mercury. It might look a little surprising to have these lower cutoffs, but this is the latest information that they are giving. And then I also highlighted that whatever is the race dependent value, blacks are more predisposed, obese people are relatively more predisposed. If a person is having metabolic syndrome, the predisposition to hypertension with centripetal obesity will be even higher. So whatever is the race dependent value, I just gave you average value, but it varies from race to race. If you are having an increase of systolic blood pressure by something in the range of about 20 millimeter of mercury, and the diastolic blood pressure is higher than 10 millimeter of mercury over these baseline values, whatever are decided on the basis of race by the global authorities, then the incidence of cardiovascular mortality definitely increases. So I have told you two things, in fact total of three things with respect to cardiovascular mortality. One, I told you that morning hours a person will be having higher chances, because you can see BP tends to rise in the morning hours. When we wake up, when we are rushing to our office, there's going to be a release of cortisol, our blood pressure also values also rise. 12 o'clock in the noon is approximately the time when our BP values are, I would say, for a normotensive% on the highest side. So most coronary events occur in morning hours. To reduce these coronary events, you obviously need good blood pressure control. You need to reduce the fluctuations in the value of the BP. And just now I said that if the systolic blood pressure is higher than 20 and diastolic more than 10 over whatever is the race dependent value, we will have a higher chances of mortality. So let's look at what the American Heart Association says and what does Harrison say for the cutoffs for hypertension. And you are very well aware of this fact that lot of controversy is there with respect to the cutoff, and it's understandable why that controversy is there, because as a physician all of us would like to have a lower threshold for initiating treatment. If you are going to wait longer, I mean, the chances of cardiovascular mortality, the chances of death in a person will also be higher. And therefore, I would say from the perspective of not only the patient, but health of a nation per se, lower cutoffs are recommended. So let's look at what American Heart Association says. And Americans are rather, I would say, towing a much more aggressive line. So what they are saying is, if the systolic blood pressure values between 120 to 129. Remember, I told you 120 is definitely not normal, and the diastolic blood pressure is less than 80. They're calling it a presence of an elevated blood pressure. And if it's gonna be stage 1, then stage 1 starts at 130. So the current cutoff for hypertension, I'll just say verbally at the moment, then I'll write it down, is 130 by 80, whereas in Harrison 20th edition and most of the older books it is mentioned 140 by 90. So it obviously depends. Like if somebody is having a higher chances of coronary events, if somebody says that my father died of myocardial infarction, this guy is himself a smoker, he is himself a diabetic, so I would try to initiate treatment of this person with a lower threshold, the one that I'm talking about at the moment. If there is no cardiovascular mortality in an individual, he's a healthy individual retired from the armed forces, that 70 years of age, he can do jogging for continuous 10 kilometers, then my threshold values would definitely be higher. So I will teach you, I mean, at what level should you be initiating hypertension, but the current information is 130 by 80 is by American Heart Association. They published this in 2017. It was met with a lot of criticism, but currently most books, including the Current Medical Diagnosis 2022, the latest edition which is now available, mentions the classification that I am talking about at the moment, 130 to 139. And diastolic between 80 to 89 would be classified as stage 1 of hypertension. Stage 2 of hypertension would be blood pressure values in excess of 140 by 90. So what you can see that in earlier times, like when I was studying, I was taught hypertension is more than 140 by 90. But currently, according to the AHA guidelines, 140 by 90 stage 2 of hypertension. That means already the target organ damage would have been initiated in the patient. Let's compare this with what Harrison says, the 20th edition, the words given up, pre-hypertension initially. So you have to remember both the classifications here, guys. If he says just the word AHA, then you should be answering what I have written on the left hand side. If he does not mention anything, then I would recommend you to answer from the textbook. Yes, answer from the textbook. Harrison 20th still goes by the routine classification, that is pre-hypertension. Then is going to be stage 1 and stage 2, but the values are mathematically different. So I would suggest you to note down this table by yourself so that you can remember, because yes, you have to remember both the values from the exam perspective. He says that if the systolic blood pressure is between 120 to 139, notice the difference. On the left hand side it is 120 to 129, here it is 120 to 139. Diastolic between 80 to 89, we call it pre-hypertension. Then you will increase by another 19 millimeters of mercury, that is 140 to 159, diastolic between 90 to 99. And then the last value coming up, thankfully, because you would be saying, sir, I have to remember so many values. Yes, guys, it's always advisable. In fact, I would suggest you to take a pic of this and, keep it in your phone, check it out a couple of times so that you can get a hang of these mathematical values that I've highlighted before you. And both of these aspects are important. I mean, it depends on the examiner. Some examiners who are following AHA guidelines can ask you in the exam, what is definition of elevated blood pressure? And if he's not gonna check out from the AHA guidelines, he might say, what is pre-hypertension? So there is definitely a slight difference in the mathematical values there. So it's a good idea to note down this information. And now we're going to talk about automated BP monitoring versus ambulatory BP monitoring. And obviously ambulatory means a continuous recording is superior over automated BP monitoring machine which is available. I mean, all of us including you and me would be having some hypertensive family member, and you would have seen these battery operated devices. These battery operated devices, when you are going to check out in the brochure which is present in them, or if you check out the display panel, the hypertension cutoff with respect to the machine that I'm talking about, the battery operated device, the cutoff there is not 140 by 90 like I'm talking about 140 by 90 from the perspective of Harrison. The cutoff in those machines is 135 by 85. So you will now say, sir, you are telling us a third value. Yes, guys, AHA 130 by 80 or higher, it's definitely hypertension. Harrison says 140 by 90. And for those battery operated devices which we are going to use at home or we can use in our office, it is 135 by 85. In fact, when you tell your patient the cutoff is 140 by 90 and the machine that he's using at his home says 135 by 85, non-medico will definitely call you up and quiz you, sir, machine is saying 135 by 85. I mean, that variations have already been calibrated. And don't be under impression that only mercury based sphygmomanometers are accurate. Even these battery operated devices, they have been tested properly and only then they have been released into the market. So provided the brand is good, they give you accurate values. So I will now be describing these terms to you like AOBP and ABPM. ABPM is still, I would say, easier to remember because I've already used this term before. That is ambulatory blood pressure monitoring. And this is the one that is recommended nowadays for diagnosis of hypertension. Instead of isolated BP recordings, he says a continuous recording will give you a better information. And AOBP stands for automated office BP monitoring. So let's look at the cutoffs and what are you supposed to do, and then I'll introduce a third term also, that is home-based BP monitoring as well, because anyway we have to talk about white coat hypertension. In office, if you have taken 3 readings, like you have called the patient maybe a Monday, then a Wednesday or a Friday, or maybe this week, next week or a next week, depending on the convenience, and you have taken 3 readings. So what you're gonna do is you will discard the first reading, and for the subsequent 2 readings you will be taking an average. This is only to increase the chances of accuracy, and the blood pressure values are documented to be more than 135 by 85 millimeter of mercury. Then based on AOBP, you can label a person as a hypertensive patient. In contrast, when it comes to ambulatory blood pressure recording, this is obviously going to be recommended. He mentions the following information. The second information is anyway important. Average awake blood pressure values, if they're more than 135 by 85, they're sufficient for diagnosis of hypertension. But he also mentions the fact that if you are going to be recording the blood pressure, why not check it even when the person is sleeping? So they documented the fact that average sleep blood pressure, the person is sleeping comfortably, right? But even then at that point of time, if the blood pressure systolic is more than 120 and diastolic is more than 75 millimeter of mercury, you would still call him hypertensive. So you can see the fact that at sleep time we are having a lesser threshold for diagnosis of hypertension because our muscles are relaxed. I mean, at sleep time we expect our blood pressure values to be anyway relatively lesser. Then there's a third term that you will always notice, that is home blood pressure monitoring. I mean, there would be a lot of patients who might be scared of coming to a clinic, or like in COVID times, you yourself would be recommending a video call, and over that you will be doing a video consultation. So when we are talking about a home BP monitoring, the cutoff is still the same for all these machines that we're gonna use. The battery operated device, it is 135 by 85 millimeter of mercury. Those sphygmomanometer based value, I told you 140 by 90 as far as Harrison is concerned. But if you're gonna be taking home BP recordings, then he says for 7 consecutive days, you will be asking your patient to record the BP once in the morning, once in the evening. It could be anytime comfortable in the morning, like after breakfast. It could be once in the evening. You will discard the first day values, because most of the time person might be anxious, so values can be relatively higher. And for the subsequent 6 days, there are 2 values again, that would be total of 12 values. So you just need to take an average of those 12 values, and if the value turns out to be more than 135 by 85 millimeter of mercury, the person will definitely be classified as a hypertensive patient. And a standard value which is anyway to be remembered is that the size of the cuff can definitely affect the blood pressure value. So you have to ensure that if a person is using a device at home, it has to be of appropriate size. Your nurse has to be trained properly, because if she will use an undersized cuff, the BP values will turn out to be higher. If she will use a bigger size cuff, the BP values will turn out to be lesser. So the cuff size should be definitely remembered here. The cuff should be covering, at least I'm talking about the length that it should be covering, so 80% of the arm circumference. I'm not talking about arm length, I'm not talking about shoulder to elbow, I'm talking about the arm circumference. 80% of this should definitely be covered. And then you can also talk about the width of the bladder. Width of the BP cuff bladder, the width should be at least more than 40% of the arm circumference. So remember 2 aspects that I've said. One is the length that it should be covering. In circumferential perspective, that's gonna be 80%. The width of the bladder should be approximately 40%. Whenever a person will come, you will not check the BP immediately. In the OPD, you will let him rest for at least 5 minutes. And suppose the person informs that he is a smoker, or maybe in the hospital canteen he took a cup of coffee, then he says that wait for at least 30 minutes. You should wait for 5 minutes overall. And with respect to a cigarette being consumed, or let me say a coffee being consumed, you should be waiting for approximately 30 minutes. That's mainly to reduce the chances of error. And then BP should always be checked in both the left arm as well as the right arm, because I am gonna be telling you conditions where there can be unequal blood pressure between the left and the right arm. And BP should also be checked in the leg. You will definitely be putting the BP cuff in the middle of the thigh, checking out the Korotkov sounds, and the Korotkov sounds would be checked over the popliteal artery. When they disappear, it would be diastolic blood pressure. When they appear, it is systolic blood pressure. And I will also teach you conditions, but one I can say right now at this moment, that is if a person is having a postductal, I'll explain what I mean by postductal. A postductal variety of coarctation of aorta, then because of the narrowing of the descending aorta, the BP in the legs will be lesser as compared to the blood pressure in the upper arms of the patient. Another aspect that we need to understand, and I'll zoom into this slide, is like you have a patient in whom office BP recordings are always turning out to be more than 130 by 80. It could be 135 by 85 also. I've just taken one of the references which is available. So in the clinic, BP is always going to be more than 130 by 80. But when you are doing a home blood pressure monitoring or ambulatory blood pressure recording, then at home the blood pressure value is turning out to be lesser than the threshold or the cutoff for hypertension. See, these values can fluctuate because I have told you 3 cutoffs. I have told you optimal blood pressure, I have told you 130 by 80, 140 by 90, and with that battery operated device 135 by 85. So you will keep on having various publications giving you various cutoffs. Like what I'm trying to explain to you at the moment is, in the clinic it is always elevated, but at home it is turning out to be normal. That means that person is having a white coat hypertension, and a person who's having white coat hypertension in future will go on probably to develop hypertension. So if in the exam says what is the management for white coat hypertension, lifestyle modification is still to be done. You will not tell this guy that okay, everything is fine. White coat hypertension does not mean everything is okay. You have to tell him, sir, there's a possibility that you could become hypertensive in future. So lifestyle modification and annual blood pressure recording can be done in these patients. And I would tell this person rather to keep or invest in this digital machine which is available available, and regularly check his blood pressure, because if it is elevated, we might have to start pharmacotherapy in these patients, or in between the period, right? He could be having a coronary event that anyway means that hypertension treatment has to be started. Now, this is very obvious. I mean, in the clinic it is more, in home it is turning out to be lesser than the threshold of 130/80. So, okay, we understand white coat hypertension, but he can trouble you with a term which is opposite or ulta of this, that is marked hypertension. So, let us understand what do you mean by the word marked hypertension. In marked hypertension, what happens is that the office BP values might turn out to be normal, but home blood pressure monitoring values are elevated. Remember, in white coat hypertension, he was okay at home, in the clinic value was more. If the MCQ gives you opposite information, that in the clinic it is turning out to be normal or slightly elevated, it could be elevated also, like you can see by the definition of AHA I taught you, this is elevated blood pressure. But when you are checking out the blood pressure values at home, they are falling into stage 1. Please listen to the data carefully. He is turning out to be having elevated, or let me say even normal values, and then it turns out to be having stage 1 when it's gonna be checked in the home. That's the definition of the word marked hypertension, which is opposite of white coat, and in this case you will have to start antihypertensive therapy. So lifestyle modification is common between the two, but in white coat hypertension I did not talk about drug treatment to be done. I said it might be required, but if he gives you a marked hypertension scenario where in the office the blood pressure values are normal or elevated, but at home you are finding that he's having stage 1 of hypertension, then the treatment of the patient is definitely to be initiated. So these are a couple of aspects which I want you to remember, and I know the fact that because I've set these multiple values, it will become a bit irritating to actually remember all of them, but it's a good idea to try and remember them, because after all in the exam any of these aspects can be asked. We shall now be talking about causes of development of hypertension. Overall, the most common cause which is to be remembered is essential hypertension, which would also be called as idiopathic, and the prevalence of this can be as much as 80 to 95%. But you are not going to tell a patient right away that I think that you're having the idiopathic form of hypertension, because this is definitely a diagnosis of exclusion. So we always should be ruling out secondary causes of hypertension by doing some baseline investigations in a patient. And one of the important secondary causes of hypertension, which means treatable causes, is renal cause. When I say renal cause, a lot of doctors casually answer renal artery stenosis. I agree that renal artery stenosis looks like a very fancy answer to say, but actually the incidence of renal artery stenosis is much lesser. In fact, in the exam, if he says which renal pathology will contribute to it, it could be renal parenchymal disease. So it could be diabetic nephropathy patient where the GFR is reducing, fairly common in our country, or all the renal diseases ultimately can progress onto a parenchymal involvement leading to CKD, and therefore the GFR is progressively reducing, RAS system is getting activated, so there would be a high renin hypertension in the patient. I will talk about other secondary causes also, but I'll incorporate a question here which said, what is the most common congenital, that is the baby is having hypertension right from day 0 of life, the day he was born. So the most common congenital cause of hypertension would be coarctation of aorta. I spoke about this condition just a few minutes earlier also. I said BP in the legs will be lesser, primarily because less blood supply would be going to the legs of this person. So also let's have a look at line diagram of it, which will make it easier for us to understand. From anatomy also, the most common site of coarctation of aorta would be answered as the starting of the descending aorta, or he might use the word aortic isthmus as well. And the problem in this person will be that because less blood will be going towards the toes, so one, he will definitely use the word differential cyanosis, though this cyanosis might be difficult to pick up in Indian patients specifically because of the darker texture of the skin. So the fingertips of these patients would be pink like you and me, but the toes will be relatively bluish in color. Differential cyanosis is one parameter, but another parameter would be that if you check the BP of this person in the upper limbs, the blood pressure will turn out to be elevated. Why did I say elevated? Because the formula for blood pressure is cardiac output multiplied by peripheral resistance. If there is a narrowing of the aorta like the way I have shown, the peripheral resistance is upgraded, and if peripheral resistance is more, the BP in the upper limb of this person will be increased. In the lower limb, it is understandable that because the flow is lesser, the volume of blood reaching is lesser, so BP will be less in the lower extremities of this patient. Well, when you compare it with BP of yours and mine, let us see what is the BP in you and me in the upper limb as compared to that in the lower limb. The way you are sitting on a chair right now, if I'm gonna check your BP in the legs, in fact, you guys can answer me here. I know it's a recorded class, but still, I have that habit the way we do it in a live class. What happens to BP in the legs, the way you are sitting at the moment on a chair? If you're lying down, then effect of gravity will not occur. But if you're sitting on a chair with your legs dangling, then the BP in the legs will definitely be higher because of gravity. You see, in upper limb, the blood pressure values will definitely be less than 120 by 90, or like I said, 115 by 75 millimeter of mercury. But in the legs, it will always be slightly higher for a normal individual like you and me. So how much is this difference? 20 millimeter. When I describe this, a query from lot of people is, sir, you changed the systolic blood pressure. Why did you not change the diastolic blood pressure? I did not change the diastolic blood pressure because that is because of aortic recoil. It's because of peripheral resistance, and peripheral resistance will not change with position. But systolic blood pressure, because of the effect of gravity, will be affected. So the message is, in a normal person, the difference between the upper and the lower limb will be in the range of less than 20 millimeters of mercury. But this situation is totally reversed in the condition that I've described before you, that is called as coarctation of aorta. So let me just draw a line diagram before you, and I'll be able to explain the variations of the blood pressure relatively better. This that I've shown is the brachiocephalic trunk, which is coming out of the arch of the aorta. From the brachiocephalic trunk, I've shown the right subclavian artery and then the right common carotid. This is the left common carotid, and this is going to be the left subclavian artery of the patient. This is LSA, left subclavian. This is RSA, right subclavian. And now I'm going to modify the diagram further by showing a coarctation. This coarctation, however, is present not at the starting of the descending aorta. It is present right bang in the middle of the aorta. So I'm talking about a preductal variety, and you can very well see the amount of blood going across this will be lesser. So amount of blood going to left arm will be less, but the amount of blood going to the right arm will definitely be normal, or can even be increased. Why? Because there is an increase in peripheral resistance. So anyway, there's a physical obstruction which is present here. So the BP on the right arm can be relatively elevated. So here you can see I have also tried to describe before you not only aspects of commonest type of hypertension, secondary hypertension, congenital cause of hypertension, but coarctation of aorta can have two varieties, a postductal one and a preductal one. The one that I've drawn at the moment is called as the preductal variety. Unequal BP between the left and the right arms would be seen in. The condition is right before you. Over and above this, I can describe one more cause which I have discussed even in connective tissue disorder, but explanation is still being provided: Takayasu's arteritis. In Takayasu's arteritis, there is a ostial narrowing. There is narrowing of the opening of the left subclavian artery. So I have just represented here, if the left subclavian artery ostia will narrow, less blood will go in left subclavian artery, but right subclavian artery is less commonly involved or not involved, so normal blood will go. So BP on the right arm will be okay, but because less blood is going to the left arm, the blood pressure on the left side will be lesser. So Takayasu's arteritis mainly involves the blood vessels which are originating from the arch of the aorta and causes ostial narrowing, which explains the unequal BP. Then I have already mentioned regarding coarctation of aorta, the preductal variety. So postductal variety would be present in the descending aorta. The third cause, very important from the exam perspective, unequal BP between left and the right arm, is called as supravalvular aortic stenosis. Here what happens is that there is a physics effect coming up called as Conda effect. What it basically simply means is that the blood is preferentially going into one artery, that is towards the right hand side. So again, preferential movement of blood due to the stenosis lesion contributes to unequal blood pressure. Supravalvular aortic stenosis is associated with, that would be overlap from pediatrics, that is Williams syndrome, which is rather seen with vitamin D toxicity. If a lady is taking more of vitamin D during pregnancy, Williams syndrome manifestations can occur. Point number 4 is not gonna be having, I would say, a chronic presentation, aortic dissection. In fact, one of the commonest causes of aortic dissection is hypertension, and once that tear will occur, the tear in the aorta will extend It can go into the carotid arteries. It can go into and cause neurological manifestations also. So when there's an antegrade progression, because if there's a retrograde progression, it can definitely cause coronary artery dissection. But if it's an antegrade spread of aortic dissection, it can again cause unequal BP between the left and the right hand side. So I've told you 4 causes for unequal BP between left and right arm, out of which point number 4 would be acute presentation, whereas top 3 would be having rather a gradual onset manifestation. Now let's just expand that list of causes of secondary hypertension that I have mentioned before you. I had initially just said one word, renal parenchymal disease. So I'll be adding a couple of more details there which are important from the exam perspective. First one is anyway the standard renal parenchymal disease. So it's his decision. He wants to talk about a person having right from childhood vesicoureteric reflux, then obstructive uropathy, damage to the kidney, and therefore a high renin hypertension. Or he can just write words like CKD or chronic glomerulonephritis. Renovascular hypertension is a separate discussion, a separate video in the app. So do have a look at that also. But I'll cater to a couple of questions here for renovascular hypertension. And one of the important causes why it is occurring in a young individual. See, when I say renovascular hypertension, renal artery stenosis in an old person, 60-70 years of age, then it's easy to identify atherosclerosis as a cause. But if I say 20-year-old young female is having renal artery stenosis, then at 20 years of age, you're not going to have atherosclerosis. So at 20 years of age, the disease which would be present is FMD, that is fibromuscular dysplasia. Though obviously if he gives you standard data, this guy is a big time smoker, he's a diabetic also, he's 60 years of age or even older, and he says what could be the reason, then your answer would be given as ARAS, that is atherosclerotic renal artery stenosis, for which you would be using ACE inhibitors. But if it is bilateral, then we do not use ACE inhibitors. The reason is given for that in the lecture for renovascular hypertension, so you need to scroll to that particular segment. And then Takayasu's arteritis can also contribute to ostial narrowing. Like I taught you, Takayasu can cause ostial narrowing of the left subclavian artery. It can cause ostial narrowing of the renal artery also, again contributing to a high renin hypertension in the patient. The third cause is important from I would say urban Indian perspective, that we Indians are sitting at home ordering food from all these apps. So centripetal obesity has definitely increased. So the disease that I'm talking about is metabolic syndrome. In fact, we can also here quickly revise regarding the components of metabolic syndrome. The first is that this guy is having a big tummy size, his centripetal obesity, his pants are not fitting him at the moment. If the abdominal circumference is more than 90 centimeter for an Indian male, and abdominal circumference goes or the girth goes more than 80 centimeter for an Indian female, it is suggestive of presence of centripetal obesity. With that will come impaired blood glucose, or I can say pre-diabetes values, primarily because if there is more fat in the body, obesity predisposes to development of insulin resistance. So fasting blood sugar of these patients will be elevated. There will also be higher blood pressure anyway because peripheral resistance is increased, and then there would be derangement in the lipid profile in a sense that triglycerides will be shooting through the roof. I did not say LDL, I said it is triglycerides, hypertriglyceridemia present, and the good cholesterol will be lesser. So there are 5 important components that you see in patients having metabolic syndrome, and out of 5 components, at least 3 should be present to say that this is metabolic syndrome. An alternative term that I want you to now remember for metabolic syndrome is syndrome X. There is a syndrome Z also. That's again a separate lecture in the app, but do not mix it with coronary syndrome X. I repeat my statement. One is syndrome X, second is coronary syndrome X. Coronary syndrome X is narrowing of the perforator branches of the main coronary artery, like you have left anterior descending, you have right coronary arteries. So the branches of those ultra small chotu blood vessels, which are getting affected is coronary syndrome X. It causes symptoms like chronic stable angina. And if he does not use the word coronary and uses the word plain syndrome X, then he's definitely talking about metabolic syndrome. Another problem, and is discussed separately in a 40-45 minute video, is obstructive sleep apnea. In fact, this is very common in America because Americans, you would see, they're very hefty. They keep on, feasting on cheeseburgers. So the neck circumference is more. There's a lot of fat in the upper airway of this person. And when this person is lying supine, there would be loud snoring occurring to the level that the person lying next to him, his spouse, may not be able to sleep. and not worried about that his family member is not able to sleep, what happens in these patients is the snoring keeps on increasing in intensity, and then there's an apneic episode. That apneic episode puts a lot of stress on the heart, because when there's hypoxia, heart will beat very, very fast. Critical hypoxia will cause a bradycardia. So heart will accelerate, decelerate, accelerate, decelerate, and therefore hypoxia causes a peripheral vasoconstriction in these patients, and that can contribute to hypertension in the long run. Obstructive sleep apnea, I have discussed, I have not jotted down the details here. I just said it verbally what happens, but have a look at the fluctuations in the heart rate during an apneic episode. There's a tachy followed by a brady. So there's a sudden acceleration, sudden deceleration. Imagine you have a car, you press on the accelerator, then suddenly press on the brakes, then the brake shoes will also wear off, and even the engine will be under stress because you're not doing a gradual acceleration, you are rather just pressing on the gas. And therefore I can say literally that this would be a literal abuse of the body. So obstructive sleep apnea is a separate topic that I've discussed, but do have a look at it. And then would come important endocrine causes. Now from the endocrine perspective, one that is important is anyway hypothyroidism. Yes, OCPs will also contribute to development of hypertension, but before that let's look at the basic problems. Like in both hypothyroidism as well as in thyrotoxicosis, you have presence of hypertension. Now thyrotoxicosis is understandable because there will anyway be sympathomimetic stimulation due to increased T3 T4, so there would be increase in the heart rate, and therefore the blood pressure values will increase. But in hypothyroidism there is always a bradycardia, no? But still there is hypertension. I mean, the query of even a patient is, sir, my heart rate is 58, my heart rate is 56. He says, doctor, I read that athletes also have a low heart rate, so I should be having a normal BP, whereas my BP is elevated. So you would tell this person that in you the peripheral resistance is upgraded due to myxedema. So in hyperthyroidism it is the increase in the heart rate, but in hypothyroidism it is the myxedema component which is responsible. And in fact in hypothyroidism you will also be having blood pressure values very outrageous ones, like 120/100. You can be having in hypothyroidism presence of isolated diastolic hypertension, though I have described this even in the hypothyroidism topic, but this is itself a question that isolated diastolic hypertension can be found in. Answer would be hypothyroidism. And I can just write an alternative MCQ here, isolated systolic hypertension. Now obviously, I mean, in some people blood pressure values both systolic and diastolic can be elevated, but let us take up a case where there's only an increase of systolic. I mean, the systolic is 160 and diastolic is 80, difference of 80 millimeter between systolic and diastolic. So isolated systolic hypertension is what you usually encounter in old age. What happens in old age is that the compliance, I'm talking about common causes, right? The common cause is that in old age the blood vessels tend to become relatively calcified. Remember in pathology you study Monckeberg's arteriosclerosis. So there is hardening of the blood vessels, there is calcium deposition in the blood vessels. So as the compliance becomes lesser, you could be having blood pressure values to be relatively on the higher side. So you definitely need to remember these aspects. And then obviously adrenal gland abnormalities are also to be remembered. It could be bilateral adrenal hyperplasia, or it could be a tumor of the adrenal gland, that is Conn's syndrome. And for identifying bilateral adrenal hyperplasia and Conn's syndrome, we talk about what is called as ARR, that is aldosterone renin ratio. And because Conn's syndrome is a tumor, it will produce lots of aldosterone, so therefore this aldosterone renin ratio will always be increased. In fact, in Conn's syndrome, because aldosterone is more by feedback, renin will be lesser, so therefore Conn's syndrome can be asked from the exam perspective in a sense that the feedback mechanism will operate in this case, and it's a autonomous tumor. The tumor does not respect physiology, so the numerator will keep on increasing, the denominator renin values can be lesser in these patients also. So this endocrine cause is definitely to be remembered. Then is among the rare ones acromegaly, where I can just say that the total body mass is more, and this contributes to again a development of hypertension. Then is OCP usage. Why do OCPs contribute to hypertension? Your answer would be secondary aldosteronism. OCPs cause hypertension due to secondary aldosteronism. So secondary causes are definitely to be thought of and evaluated, because when I will talk about workup of a patient of hypertension, you will notice that there will be a couple of tests that I'll be prescribing to a patient, like a baseline TSH values. To cut cost, I mean, you may not write a complete thyroid function test, but at least you can get a baseline TSH values to rule out secondary causes of hypertension. And when should you suspect secondary hypertension? If hypertension is identified in an individual less than 30 years of age, this is what Harrison says. If you identify hypertension at less than 30, relatively younger patient, or there is a new onset hypertension at 55 years of age, in both the scenarios, you have identified somebody very young or you are identifying somebody in the later part of life, you definitely have to think in terms of secondary causes. Like for example, I mentioned atherosclerosis could be contributing to not only a damage to the abdominal aorta, not only contribute to coronary artery narrowing, it can even be causing a ARAS, that is a atherosclerotic renal artery stenosis in a patient. Then another rare cause which can be remembered is pheochromocytoma. Here there would be a surge of catecholamine, so you will be going in for a 24-hour urinary catecholamine values, or you can go for fractionated metanephrine values and you can identify a pheochromocytoma, and the surge in blood pressure in these patients will be pretty substantial. So most of the time for MCQs of pheochromocytoma, though it is covered in endocrinology, the word written will be always episodic hypertension. The BP in these patients may actually touch normal also, because catecholamines have a short half-life, so the BP will be showing pretty substantial fluctuations. Another rare cause can be neurogenic cause of hypertension. Now if he says why, then your answer would be if a person is having spinal cord injury at C6, transaction of the spinal cord at the level of C6. So therefore below this, if there would be an unopposed sympathomimetic discharge, and therefore there could be development of high blood pressure. Then from CNS perspective, one rare cause, but still it can contribute to this, would be Cushing reflex. Cushing reflex will be having a combination of bradycardia with hypertension. This is a compensatory mechanism because after all the brain is trying to maintain the cerebral perfusion pressure. And now I will be mentioning about some rare causes for hypertension. In fact, I have gone down the prevalence order. I would say all the data that I give you is always in decreasing order of prevalence. So we are going to now talk about rare stuff, but because in our exam they have this habit of asking about rare stuff, so let's look at one of the Mendelian causes of hypertension, and the name to be remembered here is Liddle syndrome. The main problem in this condition is that there is a gain of function of the aldosterone receptor by the name of ENaC. If the channel will work more than normal, let us see what happens. I've just shown a line diagram here. This is epithelial sodium channel. The main function of this is absorption of salt and water, but I've just made a bigger arrow to say that more salt and more water will be coming in the body. That will explain the hypertension component. At the same time, in this person, there will be an exaggerated loss of both potassium as well as hydrogen. So therefore, the question will say hypertension with hypokalemic alkalosis. This has been asked in the NEET exam in the previous years. So I want you to remember Liddle syndrome is having a gain of function contributing to hypokalemic alkalosis with hypertension. He asked this primarily because he not only wanted to see that are you aware of this, but also the fact that because in this condition channel is working over time, salt in the body is more, therefore by feedback mechanism aldosterone will be less. Look at the surprising condition I'm telling you, aldosterone is less and still there is a high blood pressure, because the channel is working much more than normal, and because there is a negative feedback to the RAS system, renin will also be less. So this is the second time that I've taught you regarding a low renin hypertension. And what I'm gonna do to fix this problem, I'm gonna handle this overactive channel. And how can I handle this overactive channel? I can put on the brakes and on function by using amiloride. So the aspects to be remembered in Liddle syndrome, which follows Mendel's laws of inheritance, it's autosomal dominant, would be a low renin, a low aldosterone, and fix the channel which is working over time with use of amiloride. Let's compare this with another disease which is called as Gordon. In fact, Gordon syndrome is grossly opposite of Gitelman syndrome that I've discussed in the kidney section. So let's look at what is the problem in this case. The receptors in this case, or the channels in this case, are to be with respect to the distal converted tubule. The sodium chloride co-transporter is affected here. Mutation, the names to be remembered are WNK1 and WNK4 mutation. In Gitelman syndrome, in the kidney section, you will hear me saying loss of function of the sodium chloride co-transporter on which thiazides act. Here I am saying ulta, opposite. It is gain of function. It is gain of function of the sodium chloride co-transporter. So if you just focus on the English words there, you can see that more salt and more water will anyway be coming in the body, and more salt and more water will contribute to hypertension. Then could be polycystic kidney disease, which is of two varieties. I mean, the adult onset is autosomal dominant, the pediatric one is autosomal recessive. And since you read this topic in pathology as well, so please tell me the ultrasonographic criteria for diagnosis of polycystic kidney, that is more than how many cysts should be present per kidney to call it polycystic. You very well know that in autosomal dominant adult onset, it's gonna be mainly hepatic cysts which are common, whereas in pediatric version, you get a hepatic fibrosis. I repeat again, adults, you have a hepatic cyst. In pediatric one, it's a hepatic fibrosis, which can even cause a portal hypertension. Yes, guys, you should be having at least 2 or more than 2 cysts per kidney to say that the person is suffering from polycystic kidney disease. And then these patients could be having colonic diverticulosis also. I mean, the kidneys are big and they are cystic, so they could be bleeding in the cyst. So these patients usually get habituated to opioids from a very young age because they could be bleeding in the cyst. The bleeding in the cyst will stretch the capsule of the cyst, as well as subsequently it will stretch the renal capsule. In fact, it will stretch the wall of the cyst. If I rephrase my statement, it will stretch the wall of the cyst. It will stretch the renal capsule as well, gerota's fascias where the nerve endings are present. So therefore there would be abdominal pain. So these patients have abdominal pain for whole of their life. And apart from this, a GI manifestation that can be seen in polycystic kidney disease is colonic diverticulosis. More details you can find in the kidney section where polycystic kidney disease has been talked about. Then already I've spoken about pheochromocytoma, where catecholamine surge will be occurring, and MCQ will always give you a hint with respect to episodic hypertension. But why I chose to discuss it once again is because pheochromocytoma can be having association with multiple endocrine neoplasia type 2A, which is also called as Sippel syndrome. The components of Sippel syndrome you very well know is medullary carcinoma of the thyroid, well known by tumor marker, that is calcitonin, parathyroid adenoma, and a pheochromocytoma. It can also be associated with MEN2B, and in the endocrine section you will notice that I have described MEN2A as MEN2, but MEN2B has been described as MEN3, so that 4 varieties of multiple endocrine neoplasia. The details are present in the relevant section. Then pheochromocytoma can be genetically associated with von Hippel syndrome and can also be associated with neurofibromatosis. So it's mainly for the associations here that I've spoken about pheochromocytoma again. And now I will be showing you a diagram with respect to how our adrenal gland would be synthesizing aldosterone, cortisol, and sex steroids. Well, when you read these names, you can very well understand the condition that I'm talking about is congenital adrenal hyperplasia. The standard question that is asked on this is the commonest defect in CAH. The pattern of inheritance is autosomal recessive. So Mendel's laws are being followed. What happens in these patients is that aldosterone will be less. So in the classical variety, the salt losing variety of 21 hydroxylase, there will be hypotension, but values of sex steroids will definitely be increased. So traditional question on congenital adrenal hyperplasia will definitely talk about a kid who's having virilization, who's having this is a girl child who's exposed to higher levels of sex steroids. So therefore there is a clitoromegaly, there is a fusion of the introitus, so the vaginal opening might be closed also. So traditional varieties of congenital adrenal hyperplasia always talk about virilization of the girl baby with hypotension. But the word is but. There are 2 varieties that I want to speak at this moment which are relevant for our discussion. Traditionally, I said you always study regarding 21 hydroxylase, and that's the standard presentation of hypotension. But there are 2 varieties of congenital adrenal hyperplasia, that's gonna be 17 hydroxylase and 11 beta hydroxylase, which are of interest to me. In 11 beta hydroxylase, if I zoom it further, what will happen is that the values of 11 deoxycortisol will increase. What this 11-deoxycortisol does is it also has the capacity to stimulate the epithelial sodium channel, and if you activate ENaC, more salt and water will explain the high blood pressure that occurs in this patient. So in 21 hydroxylase deficiency, agreed there is a hypotension, but in 11 beta hydroxylase you will read regarding rather a hypertension, and this hypertension is explained by which product? That's itself a question, deoxycortisol. Similarly, if you look at this diagram with respect to 17 hydroxylase, the way I put the green line for 17 hydroxylase, you will notice the fact that it's putting the brakes on the metabolism of pregnenolone into 17 hydroxypregnenolone. So what I can see is these products are not getting utilized. In you and me, these products are utilized vertically as well as horizontally. If you put brakes here and prevent their utilization, they will be diverted towards this particular side where aldosterone is being synthesized. I said if a product is not utilized and is diverted in this direction, the synthesis of aldosterone will increase, and that will explain the hypertension of these patients. So congenital adrenal hyperplasia, specifically with respect to 11 beta and 17 hydroxylase deficiency, has a high blood pressure, but in 21 hydroxylase, no issues. I mean, that's just because since I'm discussing the topic, I had to mention regarding the standard virilization part with hypotension that you see in this child, and you have to give hydrocortisone right from the first day of life of this child with 21 hydroxylase deficiency to ensure survival. We shall now be discussing regarding a couple of investigations that should be done in this case of hypertension, and then subsequently I will be calculating what is called as ASCVD, atherosclerotic cardiovascular risk score. The objective of this is to find out what are the chances of this person dying over the next 10 years. So let's look at what are some baseline investigations that should be done to identify presence of target organ damage in these patients. Like you very well know, hypertension can contribute to left ventricular hypertrophy. So chamber enlargement can be well identified by a transthoracic echocardiography. Because these patients can be having metabolic syndrome, so I will be doing a fasting blood sugar as well as lipid profile of the patient, and along with lipid profile I can also check up for acute phase reactants like high sensitivity CRP, and anyway when there's a coronary inflammation, high sensitivity CRP values will be grossly elevated. Because of the aspect of secondary hypertension and endocrine disorders being common, I can do a baseline TSH, which can help me identify hypo versus hyperthyroidism. And then I'll be checking the urine of this patient because kidney parenchymal diseases are common. So what we are going to do with respect to the urine examination would be a baseline microscopy. And most importantly, I'll be checking for what was formerly called as microalbuminuria. But currently we do not use the word microalbuminuria. Currently we use the term moderately increased albumin in the urine. And I'll be checking out the albumin excretion rate in the spot urine sample of the patient. If you get values written like this, about 30 to 300 milligram of albumin present per gram of urinary creatinine. The denominator is not per day. The denominator would be per gram of urinary creatinine. Then you will be able to determine that the cardiovascular mortality in these patients would be increased. I would also be checking out the KFT of the patient, and I will notice in cases where there's a parenchymal disorder, the values of serum creatinine will definitely be increased. I can also get a creatinine clearance in these patients done. I can use various formulas available, online calculators for MDRD formula or Cochrane Gold formula, and I can calculate the estimated GFR rate. Along with this, the KFT test will also incorporate electrolytes, because I described a couple of causes before you where we were having hypokalemic alkalosis also present. So you would be able to pick up those rare facts also. And before you order these electrolytes, you must ensure that the patient should be off diuretics, because you very well know that thiazide group of diuretics, or any diuretic per se except for obviously aldosterone antagonist, can contribute to development of hypokalemia. So at least for 1 week diuretics should be off before you check out the baseline potassium values in the body of these patients. Uric acid is a surrogate marker again for kidney malfunction, and you will notice that in a lot of patients who are having a kidney malfunction, renal parenchymal disorder, the values of uric acid will definitely be elevated. And once I've done these baseline tests in the patient, then I can use an online calculator that I'm zooming in at the moment. This is available at multiple sites, including the American College of Cardiology website, or ACC-AHA. This will incorporate that you will have to put in gender of the patient, age of the patient, race is again an important component, systolic blood pressure, total cholesterol, presence and absence of diabetes, whether he's taking medication currently for hypertension, is he taking statins primarily, or yes or no, depending on whatever is the information available. And this online calculator can then tell you that what are the chances of this person having a coronary event in the next 10 years. Like I said, even if you get a person whose blood pressure is mildly elevated, now the word mildly elevated is just for explanation purposes. Actually, the technical word that we use is always elevation. But what I'm trying to say is that this person is not having a stage 1 or a stage 2 hypertension. He is rather having an elevated blood pressure, slightly above the threshold values, but his ASCVD risk estimation is going up to, let me say, 10%. I would definitely like to initiate treatment in these patients right away. Whereas if it's gonna be a person whose blood pressure is elevated, but his ASCVD risk calculator tells me that the risk is minimal, then I will rather start with dietary modification. I will tell this guy to exercise. So yes, I mean, DASH, which is called as dietary approaches to stop hypertension, are to be deployed in all the cases. But depending upon the ASCVD score and the baseline reports of the patient, you will decide whether to treat the patient immediately or whether you can defer the pharmacological treatment and you can start with non-pharmacological maneuvers in this patient. And let's have just a quick look at also the important target organ damages which can be occurring in these patients. Though you know this from your basic sciences and pathology, when you study about hypertension, you study about target organ damage, but I'll just enumerate what are the organs that can be damaged, and therefore you need to identify them on a primary basis. Heart can be damaged, eyes can be damaged, then it could be brain, it could be stroke, it could be ischemic stroke, it could be hemorrhagic stroke. Kidneys are anyway affected, aorta is also affected. So you can see that it is not sparing any organ, and that is why I said initially it's literally like a silent killer. So the problem with the MCQs can be, he can say which is the first organ to be affected in hypertension. I have seen in a live class when I ask what is first organ to be affected, I get varied answers, but then first to be affected is rather the heart, because it will have to do more work, and therefore what you will notice is that there would be a substantial amount of hypertrophy developing, which can contribute to ECG findings of ST depression. And if these patients are having a concomitant coronary artery blockages, then the amount of damage will be relatively more. Then he can also use this opportunity to test your information from the mini prof, where he will talk about findings of hypertensive retinopathy on a fundus examination. So let's just quickly revise them, and I'll just in fact I'm very sure that you are aware of these aspects of hypertensive retinopathy even from your opthal classes. The question will say, what is the earliest fundus finding that you will be encountering in a patient of hypertensive retinopathy? Then the earliest finding, like in diabetes mellitus, we will be having microaneurysm formation. Here what you will be having would be rather narrowing of the arterioles. So that would be focal attenuation of arterioles is the earliest fundus finding that you encounter in patients having hypertensive retinopathy. In stage 2, like if he's not taking treatment on a regular basis, he will obviously be having findings of stage 1, but there will also be presence of arteriovenous nipping. So these are some very characteristic words that he can incorporate in MCQ, and this AV nipping is also called as Salu sign. When it comes to stage 3, findings of 1+2 will anyway be present, but over and above this, there will also be presence of flame-shaped hemorrhages. Now, I can say that flame-shaped hemorrhage can even be seen with trauma. Or I can also mention cotton wool spots. Now, cotton wool spots can be seen in diabetics also. Cotton wool spots can be seen in even HIV positive patients. So if he says what is specific for hypertension, then answer is neither flame-shaped hemorrhage, because it can be seen in like trauma and so many other conditions. So is the situation with cotton wool spots. So what is specific for hypertension is what I said initially, that would be focal attenuation of arterioles. And if this guy is still not taking treatment, he will be having findings with respect to stage 4 of hypertensive retinopathy, where there would be presence of papilledema. So there are 4 words that I want you to remember here: attenuation, nipping, then cotton wool spots and flame-shaped hemorrhages, and papilledema. And then subsequently there can be even impact on the brain. When it comes to the impact on the brain, there are 2 possibilities. One can be ischemic stroke, second can be hemorrhagic stroke. I mean, don't be under impression, and I've said that earlier also, that when you read about hypertension, the bias in our mind is that it could be a hemorrhagic stroke patient, whereas ischemic stroke is much more common. So if he decides to ask you about hemorrhagic stroke, then no issues, because hemorrhagic stroke, he will usually put up this question, though I've discussed this in neurology, what is the most common site of hemorrhagic stroke? Then your answer would be given as putamen. this would be just adjacent to the internal capsule, and as the bleed will increase, it's going to be an intraparenchymal bleeding. The bleed can increase in size and it can compress on the internal capsule, and therefore you could be having a subcortical stroke developing in a patient. The kidneys will anyway be affected. I would say benign nephrosclerosis. When I say nephrosclerosis, sclerosis word implies that there would be a reduction in the glomerular filtration rate. So this is a very vicious cycle. You see, earlier I was saying that kidney damage causes hypertension. Now I'm saying vice versa. Hypertension itself causes kidney damage. So this is like a vicious circle. I mean, one disease, hypertension, other side kidney disease. Both of them are going to contribute to failing health of this individual. And then aorta can also be affected. That's rather a worst case scenario, but the examiner would love to ask about it because hypertension is the #1 cause of development of aortic dissection. So yes, you read about aortic dissection with Marfan syndrome, cystic medial necrosis, but even syphilis for the older literature, but the 70% cases of aortic dissection are actually hypertensive people. And how would aortic dissection present to you? Then in the question he will say that this known case of hypertension is today presented with chest pain. So initially any hypertension patient comes to you with chest pain at rest, you will think that it is myocardial infarction. So you ask the patient out of routine your habit that okay, put your hand where the pain is present, and you expected the patient will put his hand on his chest like this or the fist on the chest. I was thinking that the person will be describing a Levine sign, but what really happened was the person surprised me by putting his hand not in the front of the chest, though pain might be present anteriorly. He said, doctor, I'm having excruciating pain, and he's going to put his hands like this between his shoulder blades. So when you read about chest pain at rest, which is mainly concentrated in the interscapular area, this is one of the very good points that tells you that this could be aortic dissection occurring in a patient. And apart from this, there is also possibility that this aortic dissection can travel anterogradely or it can travel retrogradely. If it will travel retrogradely, there can be coronary artery dissection. Then this guy is doomed because you cannot do thrombolysis in coronary artery dissection. So if the tear goes in backward direction, I would say the chances of survival will even be lesser because of coronary artery dissection. If it travels anterogradely, even then there's a problem obviously because there could be involvement of the internal carotid artery. Internal carotid artery is the main supply of the brain. So there's a possibility that he might start talking about neurological features developing in this person. So as this I would say tear in the aorta progresses, it starts from intima and the blood splits between or travels in the media per se. So you are having a false lumen being created in the aorta, and this could contribute to pressure on the stellate ganglion, and therefore Horner syndrome manifestations could also be developing. Now why this is very interesting is because in a single question you would be having not only features of acute coronary syndrome, but the same patient is having neurological features also. I mean, this has no parallel. I have not described any condition where I have described person having cardiac issues also and brain issues also. Obviously, when I talk about atrial fibrillation, okay, I mean the clots can go into the brain, logical aspect. But to have a patient having chest pain at rest and simultaneously neurological features is unlikely with respect to routine presentations. But yes, you do get this with respect to aortic dissection. So I need to do a good workup of these patients. And in the workup of these patients, the answer will depend upon, the investigation choice will depend upon the blood pressure values. For example, if the patient is hemodynamically stable, then I can definitely do a CT angiography in the patient. But if the person is hemodynamically unstable, then I would have to do a bedside investigation, and the bedside investigation that I'll be doing in this patient would be a transesophageal echocardiography. So blood pressure values help us decide, and with CT angiography anyway, there's a very characteristic manifestation that appears, and that's because of the intimal flap that is created. I said the blood goes through the intima, tears into the media, and then is circulating freely in the media per se. So the CT angiography findings of these patients would be having this characteristic tennis ball appearance. Over and above this, he can also ask you regarding the types of aortic dissection, which can be of two varieties, type A and type B. Well, type A is present anteriorly. When I say type A aortic dissection, it is anteriorly present, anteriorly present. That means that it is mainly involving the ascending aorta of the patient. So in type A, there would be a possibility of this person definitely having neurological features. That's okay. I mean, it can go up from the arch of the aorta to the internal carotid artery. But type A, the person will will be, I would say, in a bad situation and you would require surgery to be done for these patients. But when it comes to type B, there can be two possibilities in the question for answer. One is that the blood pressure is very low. In those circumstances, if the blood pressure is very, very low, again, it is surgical repair, urgent surgical repair that is required. But if I say that BP is less, but not so less to the level that there can be, I would say, problems with the blood supply to the kidney or other vital organs. You see, I put two double arrows initially, then I put a single blood arrow. All I'm trying to say here is that if auto-regulation of the vital organs is going to be affected, I would plan an urgent surgical repair. But if it's going to be initial stage where the blood pressure fall has just begun, then I can give this patient pharmacological treatment as well. What I mean by pharmacological treatment is not that it will repair the tear, but what happens is when there's a tear happening due to sympathomimetic stimulation, chest pain occurring in this guy, the heart will beat faster, and the faster the heart will beat, it will increase the speed of propagation of the tear. So all I need to do is put on the brakes and give esmolol to this patient, and this esmolol, all it will do is it will slam on the brakes, reduce the heart rate, it will reduce the propagation of the tear in this patient. In some situations, he might deliberately put up hypertensive crisis in this patient. Why hypertensive crisis when the aorta is damaged? Because the body will try to compensate. So there will be a peripheral vasoconstriction, and this would be again a disaster situation. Why? Because now the heart will have to work harder, and when the heart will work harder, that means that the tear can increase even further. So a vicious cycle has been set up. There's a peripheral vasoconstriction in these patients. In these circumstances, I will be having to use a alpha blocker in these patients. In fact, when I give labetalol, the advantage is it will not only control the heart rate, but it can also help me in neutralizing the peripheral resistance that has increased dramatically in these patients. So when you are attempting these questions, one, if they give you a CT image, look at whether it is ascending or descending aorta that is involved. If it is ascending aorta, it is urgent surgery. If it is going to be type B, aortic dissection posteriorly located, check out the blood pressure values. If they are in range of less than 80/60, that's when you'll say okay, surgical repair. If then let me say 100, 90, something like that, then it's okay, you can give medical treatment to the patient initially, and if he says crisis, then obviously labetalol would be used. Next, I'll be explaining to you regarding when to treat a patient and how to treat a patient. First of all, we focus on when to treat a patient. So we are going to select a single agency here because there are multiple guidelines. One is from Hypertension Canada, then is European Society of Cardiology. The baseline textbook that I'm using here is CMDT, Current Medical Diagnosis and Treatment 2022 edition. So this is what the American Heart Association says with respect to when to treat, what is the threshold then you would like to intervene. You see, there are two separate aspects. One is what is the target blood pressure to be achieved. So I can just say a standard figure 130/80 or lesser if patient can tolerate. The important thing is tolerance from the patient's perspective, because if you're very, very aggressive in management of hypertension and he ends up with a postural hypotension, he goes to washroom, falls down, ends up with a head injury, you have caused a loss. So the message is, in medical science, it's not about a mathematical number that is to be achieved. It is whatever the patient can tolerate. So I just gave you a figure which, if asked in the exam, your target is about 130/80 that is to be achieved. And that is what we are doing currently. You would have seen so many cases in your hospitals also where persons have already suffered from MI, or they are having a family history of heart disease. They might be diabetic as well. So if the atherosclerotic cardiovascular disease risk is increased, and there's online calculators available for it, if the risk comes out to, let me say, 10% over next 10 years, pretty substantial, then I will start treatment even if the blood pressure of the patient is, I would say, less than 130/80. Do look at the symbol there. I'm not saying more than 130/80. The AHA says that in a guy in whom already suffered from MI, be aggressive in management and try to treatment or give treatment even if the blood pressure is less than 130/80. For people in whom the risk is not increased, let me say he is a person who works with paramilitary forces, or he's a fit individual. He might be working in corporate. He goes for a run on a regular basis. He does running for 10 kilometers on a daily basis, and he's a non-smoker, non-diabetic, pretty fit chap, and I'm finding out on an annual medical checkup that he's hypertensive. Then when would I like to initiate treatment? That's gonna be treatment here basically means that obviously non-pharmacological measures are anyway to be instituted, but when would you like to start the patient on drug? drugs is what I'm trying to teach you here. So this information per se is primarily from the perspective of when would you be prescribing drugs to a patient. So for any individual where the ASCVD risk is on the lower side, you can start pharmacological treatment if the BP is more than 140/90, and in old age again we are keeping a threshold as 130/80, and especially old people are vulnerable to chances of postural hypotension. So especially when you're using calcium channel blockers, or even when you are using ACE inhibitors, both of them can contribute to fall in blood pressure to the level that these patients can sustain a head injury. So the reference, as I've mentioned, is current medical diagnosis and treatment, CMDT 2022. Then is how to treat these patients. So according to the guidelines, if the age of the patient is less than 55 years of age, the first line drug that you can introduce in the patient is either A or C, and you can obviously combine the two also. He says either of the two drugs can be initiated, and if suppose you have used the maximum dose of ACE inhibitor and it's not causing an improvement, you can definitely add calcium channel blockers. If there is still no control of hypertension, then you can even add third category, that is thiazides. But whenever you're giving thiazides to the patient, you must remember they can cause a derangement of the lipid profile in the long run. They can cause blood sugar values to get elevated. So HbA1c values in the patient can definitely increase. If the age group of the patient is more than 55 years, then the textbook says first you should be starting with calcium channel blockers. The message here is younger patient it is ACE inhibitor, in older patient it is calcium channel blocker. And if obviously alone with CCB you're not getting a good result, you can definitely add ACE inhibitors to these patients, and then if required you can add thiazides also. And I will definitely teach you the definition of the word resistant hypertension, which is of paramount importance at this point of time. But at the moment I just wanted to say that based on the age group of the patient, the initial drugs can be either A or C, and then you can obviously keep on adding drugs in the later part. If you are not getting an improvement, you can even add aldosterone antagonist in the patient also, because especially patients who are having a high cardiovascular risk, they will be definitely benefited with spironolactone. In fact, if you listen to my discussion of heart failure, with hypertension we have heart failure with preserved ejection fraction. There you have a diastolic malfunction. Now preserved does not mean that obviously the ejection fraction is normal. Preserved simply means the artificial cutoff of cardiac output has been kept to be values in excess of 50% of normal. I mean normally when we are checking out the ejection fraction of the heart, the value that is taken is to be 65%. If the value is arbitrarily more than 50%, I will say it is preserved ejection fraction. If it's gonna be less than 40%, I'm gonna call it reduced ejection fraction. So most hypertension patients will have a diastolic malfunction of the heart. The left ventricular end diastolic pressure will be elevated, and they can develop heart failure with preserved ejection fraction. In those circumstances, even aldosterone antagonists have been shown to lower mortality. So a lot of information for drugs coming up now, but this was just the initial part that I've highlighted. And again, this is what the textbook says. I mean, step one is you can start with the ACE inhibitor or ARB. I mean, obviously with ACE inhibitor, you can be having problems like dry cough. So if somebody is a public speaker and he says, I have this cough primarily because of excess production of bradykinin due to usage of ACE inhibitors, which you know from pharma, then you can use ARB for the patient. Though if there is an angioedema component present, then there is definitely bound to be problems in the following perspective. Angioedema is one of the big problems that you see with ACE inhibitors, but it can also be seen with ARB. It can even be seen with a direct renin inhibitor, that's gonna be aliskiren. So there are three A's that I mentioned at the moment, and all these three A's they definitely can contribute to, or they are responsible for angioedema. So if angioedema is developing and the question says what would you use, you will be more comfortable using calcium channel blocker for the patient. So as you can see here, step one would be ACE inhibitor, CCB or thiazide diuretic. Depending on the age group, A and C are preferred. Then you can make an addition. You can keep on adding drugs. Then you can see that the plus has increased 2 times. That means it is A plus C plus B, or it is C plus A plus thiazide group of diuretics. And when would you like to use beta blockers? Then I want to say that especially if a person is having coronary artery disease, the main usage of beta blockers with respect to hypertension would be that if a person is having documented coronary artery disease, and even if he's having chronic congestive heart failure, I repeat the fact once again, chronic stable angina, two chronic words coming up, chronic stable angina, chronic congestive heart failure, that is when beta blockers can be added at any stage per se. And whenever you are making a decision to add one drug, like you have given maximum dose of ACE inhibitor, it's not producing a substantial reduction in blood pressure, the values are still elevated, what you are gonna do is wait for 2 weeks for the drug to have its full effect. And if even after 2 weeks there is no improvement, the blood pressure is not coming down, you definitely can add an additional category of drugs. Additional point that I would like to add up here is that lifestyle modification has to go sync in hand. In any person in whom the cardiovascular mortality risk is lesser, you anyway start with lifestyle modification. So that's anyway a standard treatment protocol, and the technical term that is used to describe that is DASH, that is dietary approaches to stop hypertension. It means that the salt intake has to be reduced, potassium intake in the diet has to be increased. The diet is to, the person is supposed to, rather go less on red meat. Red meat increases the incidence of heart disease. You're supposed to take white meat, increase the intake of nuts, increase the intake of vegetables, and regularly exercise. Light aerobic activity for approximately 30 minutes per day for 5 days, that's about 150 minutes per week, will substantially go a long way to control the hypertension component. And along with this, if he can do yoga, if he can do a breathing regulation, that would be an additional benefit. So non-pharmacological steps are anyway to be utilized in all the patients who have been identified with either elevated blood pressure or any of the stages of hypertension. But our objective is mainly to talk about when to initiate pharmacological treatment. That is what I've explained in my previous slide, when to treat in a patient, and then on the standard drugs which will be introduced. But in the exam they also love to ask regarding what is resistant hypertension. Resistant hypertension means that you have used at least 3 classes of drugs. Like I was describing A with C with D, you have used 3 classes of antihypertensive medication and still the blood pressure of the patient is on the higher side. So we will now be studying what is one of the important reasons. In fact, that itself can be a question, what is the leading cause of resistant hypertension? Then my first answer will sound a little funny to you, that is incorrect recording of BP. There's a possibility that either the person is doing home monitoring by himself and he's telling you, sir, my BP is always elevated, it's not coming down. Second possibility is that the nursing staff of yours is not trained properly, they're not recording the blood pressure properly, so it could be errors. But assuming the fact that the person is educated and your nursing staff is highly qualified and you yourself have taken the blood pressure of the patient and you're still finding it to be elevated, then what would be the reason? So if measurement is not an issue, then it would be non-compliance on the part of the patient. You see, for you and me as doctors, it is very easy to say take 1 tablet a day or take 2 tablets a day. But when you're going to check out the strip of a person, you will notice the fact that they might be missing out the tablet on a couple of days as well. So non-compliance is, in fact, I'll just jot it down, non-compliance on the part of the patient, that is assuming that you have taken care of the measurement component, measurement bias is not there. Non-compliance happens to be the number 1 reason why this would be happening. And second could be excessive salt intake. So I list down those causes before you, but the definition is at least 3 classes of antihypertensive medication is concurrently being used in the patient. It is concurrent usage of all the 3. And these 3 classes must include, that's important point from the exam perspective, what drug should have always been prescribed before you say okay it is resistant hypertension. Textbook says must include thiazide group of diuretics to be introduced for at least 2 weeks. And well, even then, if you are having uncontrolled elevation of the blood pressure, that implies that he is having resistant hypertension. The most common cause I've already enumerated before you, but there are a couple of others which must be taken into consideration, and these would be involving usage of medications like COX-1 inhibitors. You very well know that if a person is misusing painkillers, right, maybe because he goes to a gym every day and he has these muscle pains, he is using painkillers on a regular basis, because he wants to regularly work out, or let me say he's into martial arts and he sustains a couple of injuries. He had a ligament tear, and ligament tear he did not get any arthroscopic repair done, but he wants to continue with the exercise component. So COX-1 inhibitors are being used on a regular basis. They will affect the renal hemodynamics, and damaging the renal hemodynamics can contribute to elevated blood pressure. Then can be recreational usage of drugs. So especially in young people, you have to be wary regarding usage of cocaine on a recreational basis. Then another aspect which should be remembered is usage of steroids, because this guy, he is into, let me say, bodybuilding, or he just wants to show off that I have big muscles. So he could be using steroids, which again can contribute to increase in blood pressure. You could be having a CKD patient who's using erythropoietin. So these are couple of drugs which can contribute to having a poor result with respect to antihypertensive medication. Routine causes, I've already mentioned, it is non-compliance, but obviously improper, that's what is written in the textbook, improper BP measurement must be ruled out. Calibration is to be done, standardization is to be done in your clinic, so that you don't over report cases. Then from the dietary perspective, excess salt intake. This guy adds liberal amount of salt to his food, to his curd that he eats, to the salad that he eats, and he eats pickles also. Pickles are loaded with salt, so that will again contribute to problems in this patient. Then another component can be obesity. You see, a person has to do light aerobic exercise. Weight loss helps in substantial reduction in lowering of blood pressure by something like 5 to 10 millimeters of mercury for every 10 kgs of body weight loss. I agree that 10 kgs of body weight loss is very difficult to achieve, but then if centripetal obesity is present, then the chances of your medications not working would definitely be affected. Along with this, regular alcohol intake by a person can result in resistant hypertension. So these are a couple of causes which are to be considered whenever resistant hypertension is asked, and obviously the most common cause is what I've enumerated. Next, I'll be describing a couple of drugs which are useful for management of hypertension. So this would be a revision of pharmacology for you guys. Beta blockers, the common ones which are used are carvedilol, and another one is metoprolol. And both of them are specially useful for patients who are having chronic stable angina. So hypertension with CSA, or a person having chronic congestive heart failure, is where beta blockers can be added at any of the stages. It could be A plus B also then subsequently in a cardiac patient. Like when I've described heart failure topic, I would really suggest you to listen to the heart failure topic after this, so that this particular line that I've written becomes much more clear to you. The next drug that I would like you to remember is ACE inhibitors and angiotensin receptor blockers. From pharmacology, I hope you recall that ACE inhibitors are contraindicated in bilateral renal artery stenosis. The exam actually said why. And the reason for this is that ACE inhibitors can trigger development of acute kidney injury in bilateral renal artery stenosis, because they'll cause a efferent arterial dilatation. So the gradient at which the filtration occurs in the glomerulus is lost, and therefore renal failure can occur. I have described renal artery stenosis separately in the kidney section, so I would like you to listen to that component also, though I've already given an explanation. And if he says where would you prefer these drugs, then obviously hypertension with especially post-MI patients. And the threshold I told you was, I'm not going to wait for the BP to go beyond 130 by 80. Even if it is less than 130 by 80, he's already sustained MI. We have to give low dose ACE inhibitors for the patient. The next important indication is heart failure with reduced ejection fraction. So I taught you that if it's a heart failure with preserved ejection fraction, then you are going to think in terms of aldosterone antagonist. But if it is heart failure with reduced ejection fraction, ACE inhibitors definitely matter. And then even in diabetic nephropathy, because there is a high renin hypertension, ACE inhibitors would be prescribed. What they also did was they decided to prescribe ACE inhibitors to diabetes mellitus patients before they developed a nephropathy. Studies showed that it produced no benefit. So only when there is a documented diabetic nephropathy. And how do you demonstrate diabetic nephropathy? Then in earlier times we used to use the word microalbuminuria, but currently we just say moderately increased albuminuria, 30 to 300 milligrams of albumin if present per gram of urinary creatinine. Diabetic nephropathy is present. The screening test for diabetic nephropathy is urinary albumin creatinine ratio, or albumin excretion rate. The values that I've said before you, 30 to 300 milligrams per gram of urinary creatinine. So if that is documented, we will start the person on low dose ACE inhibitor. I will not wait for the serum creatinine to double. I'll not wait for the biomarkers of acute kidney injury to start getting grossly elevated. We should try and identify and manage these patients initially. And I would also like to say that one of the big disadvantage of ACE inhibitors is obviously development of hyperkalemia. But in the textbook, he says that if hyperkalemia is developing, don't stop ACE inhibitors directly, especially in diabetic nephropathy patients in grade 1 or grade 2 or grade 3. The benefit is much superior as compared to the loss. So the query from your side would be, sir, after all, person is having high potassium, would he not be having cardiac arrhythmias if you're saying potassium is elevated? So he says, okay, if with ACE inhibitor you are having a elevated potassium, like normal is 3.5 to 5.5, values coming as 5.8. So what should I do? One is I should stop ACE inhibitor and I lose the benefit. Second is I can be giving these patients novel agents, newer agents for reducing the potassium value. So I'm talking about chronic hyperkalemia, one of the very effective drugs that we have now for management of these patients of chronic hyperkalemia. You see, acute hyperkalemia is obviously dangerous. There obviously, ACE inhibitors are anyway to be stopped. If it is chronic hyper K, 5.8 coming on a consistent basis, you can be using patiromer, or you can be using sodium polystyrene sulfonate, which comes by the name of K-bind. It is available in tablet format and enema format. And for patients of CKD, the objective is to use these agents to try and get potassium back to normal. Now, I agree to the fact that if potassium cannot be brought back to normal, even with the usage of these drugs, or cost is a barrier, then switch over to calcium channel blocker. Absolutely no issues with it. But the message is in ACE inhibitor, especially in diabetic nephropathy patients in grade 1, grade 2, grade 3, the initial phases of diabetic nephropathy, CKD development in a patient, ACE inhibitors, we should try to continue with them as long as possible. If it is not possible, GFR goes to less than 30, goes down to 15, then absolutely no issues. Then you can be using calcium channel blockers also. You can be using alpha blockers in the patient also. The next drug category that we'll study is aldosterone antagonist. I'm talking about spironolactone and eplerenone in these patients. I've already sensitized you to the fact that they would be especially useful in those patients of hypertension who are having heart failure with preserved ejection fraction. This is an artificial cutoff that the ejection fraction of the patient is more than 50%, but obviously lesser than normal. Then comes the role of alpha blockers. So when would alpha blockers be useful for management of any patient of hypertension? I'm talking about drugs like prazosin, trazosine. One of the very important roles of where alpha blockers would be useful would be a hypertension patient with enlarged prostate. Because when I use alpha blockers, I'll not only be having control of blood pressure, but even the obstructive uropathy component of this person of enlarged prostate would be reduced. The second important rule would be with respect to pheochromocytoma. In fact, pheochromocytoma, they can ask you about intraoperative hypertension, but at the moment I'm talking about management of preoperative hypertension. And you see, pheochromocytomas are mainly benign. Only about 10% could be malignant. So in majority of cases, surgical resection can be done, but no anesthetist would give you anesthetic clearance for somebody who's having elevated blood pressure. So first you need to bring the BP back to normal. So to get a pre-anesthetic clearance for a person of pheochromocytoma so that I can enable surgery in the patient, I can be using a non-selective alpha blocker here. That would be phenoxybenzamine. And the advantage of this drug would be that it will neutralize all the peripheral vasoconstriction which is occurring in these patients. So the message is pre-operative hypertension in a pheochromocytoma patient is managed with, the answer would be phenoxybenzamine. Intraoperatively, we definitely can be using nitroprusside, nitroglycerin, and we can be using phentolamine also. But at the moment, I specifically wanted to remember for preoperative. And then if a person is having diabetic nephropathy and he lands up in end-stage renal disease, then I definitely can be using alpha blockers in the patient. And this was actually asked in the NEET exam also, that a patient of diabetic nephropathy has now gone into ESRD and the BP is not getting controlled by routine drugs, and even he's having substantial edema all over his body. So what drug will you use? So options were alpha blocker, beta blocker, calcium channel blocker. Why I will not use beta blocker at the moment, or why I will not use calcium channel blocker, is primarily because calcium channel blocker at this particular point of time, there is already edema in the body. You very well know that CCBs also cause an ankle edema, and beta blocker at this moment will not neutralize the substantial amount of peripheral vasoconstriction which will be present in this patient. Because after all, why are we having substantial amount of hypertension in ESRD? It is high renin state, aldosterone values are elevated, angiotensin 2 values are elevated. Angiotensin 2 is a powerful vasoconstrictor. I cannot use ACE inhibitor at this point of time because of the fact that potassium will be grossly elevated. So the only drug that I'm left with is alpha blocker. Please remember this fact. If it is CKD in a patient, initially you can be using thiazides also for control of hypertension. You can be using ACE inhibitor in a patient. But when the situation becomes really dicey in a sense that potassium is elevated, ACE inhibitors can't be used, peripheral vasoconstriction is substantial, then alpha blockers can definitely be used. So three important usages are a person with enlarged prostate, preoperative management of pheochromocytoma, and end-stage renal disease. Now we are going to talk about two important aspects. One is called as hypertensive urgency and the next one is called as hypertensive emergency. And again, I'm going to give you some conflicting values at this point of time, because over the internet you will notice that the cutoffs for urgency emergency are given to be 180 by 120, whereas the image that I'm showing you from current medical diagnosis and treatment CMDT 2022 mentions the fact that the blood pressure values in excess of 220 by 125 millimeter of mercury. So what should you answer in the exam? See, from the exam perspective, I can say that you should always go by textbook reference. Harrison is not given any cutoff for urgency or emergency, so I had to look up CMDT for the same. Yes, I also want to tell you that it is not actually the absolute value of blood pressure that matters for urgency or emergency. Let me just put up this data before you. Suppose I mention the fact that person's blood pressure is 220 by 130. Just for reference sake, at the moment, listen to this, don't note it down. Blood pressure of a person is, let me say, 220 by 130 millimeter of mercury, but there is no target organ damage, minus TOD. Then only BP is elevated. I'm going to call it urgency. Whereas suppose the blood pressure of the person is 220 by 130 or 125, whatever is the current value, but there is presence of target organ damage, then I'm going to call it emergency. Guys, what I'm trying to teach you at the moment is that why has Harrison not given you a mathematical value here is because he says for any person with elevated blood pressure, suppose it is 170 by 110, will I just say to the patient, okay, because you are not fulfilling this cutoff, you are not suffering from urgency or emergency? It is not the mathematical value, it is presence or absence of target organ damage that will decide whether you are gonna admit the patient immediately or whether you're gonna put him on ACE inhibitors. You see, it is the presence or absence of target organ damage that's more important a criteria than the absolute value of blood pressure. Yes, you should try to identify early. I mean, somebody comes at 170 by 110. It's not that I'm going to wait for the blood pressure to go beyond these mathematical values and then I'll say, okay, I will treat you. For urgency, if he says what is the treatment, you just need to give ACE inhibitors to this patient, considering that the age of the patient is less than 55. If more, we can be using CCBs also. But if it's going to be an emergency, then in those circumstances, the drug lowering has to be substantially fast. And I'll describe what are the drugs that can be used and what are the situations that can be given to you in the exam. So the more important perspective from urgency and emergency perspective is the presence of target organ damage, which will be discussed subsequently. And then there's another term that comes up, malignant hypertension. Well, why do they use the word malignant? Because malignant is primarily for cancers. The reason why the word malignant is used is because blood pressure is rising in these patients very fast, and the mortality in these patients over the next 1 year can be as high as 50%. You can very well see if somebody is diagnosed with a lung cancer, small cell cancer of the lung, he may die over next 1 year. So just like a cancer develops very, very fast, the mortality rates here are very, very high, and this chap could be having a pre-existing hypertension which is suddenly now deteriorating. And in malignant hypertension, the target organ damage could be in the form of retinal hemorrhages occurring in the person, or it could be putaminal bleed, intraparenchymal bleed, It could be nephrosclerosis and the person's kidney status has deteriorated. Even blood vessels can be damaged in malignant hypertension. In fact, one more target organ damage added to your vocabulary. The blood vessel damage that you can see due to very high blood pressure is called as microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia is discussed with respect to hemolytic uremic syndrome, where you read about Burr cells, you read about schistocytes in the peripheral smear. So today I've just increased your vocabulary by saying that microangiopathic hemolytic anemia is one of the target organ damages. So even blood vessels, small blood vessels can be affected in hypertension, and uncontrolled blood pressure can contribute to this particular manifestation. Now, what is the drug which is preferred for management of any patient in whom the BP is so high that the brain blood vessels have undergone a protective spasm? I did not say that there is a bursting of any blood vessel of the brain. I am simply saying in any patient in whom the blood pressure is spiking, going through the roof, 220 by 130, at the moment there is a protective vasospasm due to which the person has become unconscious. So to lower the blood pressure values of this patient, I can be using sodium nitroprusside. This is the standard drug that we always read in pharmacology, but what I say next has to be listened with lot of care, because hypertensive patients can be having CNS events. If he mentions the word stroke in the MCQ, then do not answer nitroprusside. I'll give you the reasons why. Only if in the MCQ he uses the word hypertensive encephalopathy, that is when you are supposed to answer a sodium nitroprusside. In fact, hypertensive encephalopathy is one of the forms of hypertensive emergency that could be occurring in a patient. So hypertensive emergency can be development of left ventricular failure. If left ventricular failure will be occurring, what will I use? I will use IV nitroglycerin. Nitroglycerin will lower the blood pressure of the patient also, and it will treat the pulmonary edema component also. And unfortunately, if in the patient you are having a development of stroke, like he mentions person has had a ischemic stroke, then there can be two possibilities. Person is gonna receive thrombolysis or not. You very well know that we use retaplase within the window period of 4.5 hours. So if a person comes within the window period, obviously thrombolysis has to be done. So when should you do thrombolysis? You must always ensure the fact that the blood pressure of the patient when thrombolysis is to be initiated should be less than. In fact, in the exam he has said blood pressure more than how much, listen to my words carefully, blood pressure more than how much would you not do thrombolysis? Blood pressure if more than 185 by 110 millimeter of mercury, you are not supposed to do thrombolysis. Immediately first lower the BP, then do thrombolysis. And to lower the BP, what drug would be used in this case? Then the answer here would be given as nicardipine. In fact, I'll just show you the reference from CMDT also in a while. But you see, why not sodium nitroprusside? Because nitroprusside is a very efficacious drug, but it causes a fast fall of blood pressure. Because of this fast fall of blood pressure, what happens is that the cerebral perfusion pressure can be affected. Cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. If you lower the MAP, CPP will also get lowered, and you are rather causing harm to your patient, because if you decrease the blood supply to the brain, it will contribute to brain infarction. The chap came to you with already a ischemic stroke, and if you cause further worsening of blood supply to the brain, the ischemic stroke will definitely worsen also. So we will be more comfortable using drugs like nicardipine and clevidipine. Advantage of these drugs is you can titrate how much millimeter fall will occur over next couple of minutes. You need to titrate the fall of blood pressure to a controllable value, lower the value to this particular statement of mine less than 185 by 110. In MCQ, he deliberately asked more than how much, so the answer will be more than 185 by 110. I'm not gonna do a thrombolysis. First, I will lower the BP. The word is, and that's why I'm highlighting this statement. I mean, any chap who's a candidate for thrombolysis, he has presented in first 4.5 hours. I will first lower the BP to this particular threshold, and then I can do thrombolysis in the person. Because if I do thrombolysis at a value higher than this, he has said, God forbid, thrombolysis also has a side effect, no? IC bleeding. He says, God forbid, if somebody, God forbid is just to exaggerate, if somebody is going to have a CNS bleed and blood pressure is on the higher side, then the bleed will worsen, no? So you need to remember, blood pressure more than 185 by 110 in a guy who's a candidate for thrombolysis, who's landing up in your casualty in the window period for thrombolysis. If the blood pressure is higher, try to lower it to this particular value, and then you can proceed with thrombolysis. if he is not a candidate for thrombolysis. Now this is unlikely to be asked primarily because you see if person comes late anyway, nothing much can be done. It's only conservative management that would be required. Then the cutoff that is required is about 220 by 130 millimeter of mercury. You see in the CMDT reference it was 220 by 125, though I wrote 220 by 130. So these minor variations can definitely be present in different references, but then the more important agenda here is to get this mathematical value right. Then there's another new entry in the CMDT for intracerebral hemorrhage, which was not given in the previous editions of any textbook. He says if the person is having a icy bleed, then you definitely have to lower the BP. He says for intracranial hemorrhage, the target blood pressure of the patient should be in the range of about 130 to 140 millimeters of mercury. So remember, the threshold that we are keeping for brain hemorrhage is on the lower side for target blood pressure, whereas the target I want to achieve in ischemic stroke is relatively higher, and the logic is straightforward. Higher blood pressure in brain hemorrhage means the bleed will also be increased. Now, another scenario he can ask you is that after MI, there's a substantial peripheral vasoconstriction contributing to high BP. Post unstable angina episode, he's having severely high blood pressure, or he simply says known case of hypertension, underwent gallbladder surgery, and after gallbladder surgery is BP spiking. So what drug can be given for these patients? Your answer would be IV nitroglycerin. You very well can understand why I have said nitroglycerin here and not calcium channel blocker, because nitroglycerin will help in managing the pulmonary edema component if it develops in these patients, and apart from that it will also contribute to the vasodilatory effect and control the blood pressure of these patients. If it comes to adrenal issues, like he mentions that the person is having adrenal crisis, like this is a pheochromocytoma patient and he's having a hypertensive spike during surgery. The message is, during pheochromocytoma surgery there will be tumor manipulation by the surgeon. The tumor manipulation can cause a catecholamine surge and the blood pressure values will dramatically rise. So in those circumstances, for management of intraoperative hypertension, I can be using sodium nitroprusside, and if I don't have it, then what I can do is, before the person is wheeled into the OT, I can give intramuscular phentolamine. Now, obviously, the control with intramuscular will be very, I would say, imprecise. So I'll be more comfortable using sodium nitroprusside in this case. So I've expanded your vocabulary by telling you that in pheochromocytoma patients, if it is going to be pre-operative, it's going to be phenoxybenzamine, but if it is going to be an intraoperative hypertensive situation in a patient, then IV sodium nitroprusside can be given. And if he goes into heart failure at this point of time, like the BP spiked so much that even before you could use sodium nitroprusside, even before phentolamine had its effect, the BP suddenly spiked due to tumor manipulation, he goes into heart failure, then you don't have an option. You will have to use IV nitroglycerin in the patient. So for hypertensive emergencies, guys, there's a table in the textbook, and I'm just zooming it in for your convenience just to prove before you the fact that why have I spoken about nicardipine so many times, especially with respect to ischemic stroke, especially with respect to intracerebral hemorrhage. And you can also see that the cutoffs that I've described before you, 185 by 110, 140 is approximately to 160 are well documented in this case. If there's a cardiac involvement, we can be using nitroglycerin in a patient, NTG, or we can be using, nicardipine as well. For cardiac events, either of the two drugs can be used. It depends on situation. I mean, I first mentioned nitroglycerin for the patient because my patient is having chest pain as well. He's having pulmonary edema component also. If the chest pain component is not present, then we can use nicardipine. But you can very well see he has mentioned recommended drugs, and nitroglycerin is very much present even for cardiac events in this case. So one, you will notice that sodium nitroprusside is not mentioned in this particular list in the current segment that you can visualize. So when are you going to use sodium nitroprusside? Your primary answer is going to be mainly with respect to patients of hypertensive encephalopathy, where there is no CNS bleed, there is no ischemic stroke in a patient. Now towards the end of the discussion, I am going to describe before you what is the target blood pressure values which are to be achieved in various populations. For routine hypertension, Harrison has tried to play it a little safe, and he has mentioned that try to keep the systolic between 135 to 140 and keep diastolic between 85 to 90 millimeters of mercury. He says try to go for the lower limit if tolerated. In diabetic nephropathy, there will obviously be a question and there will be a debate on this also, because in some books it is mentioned for diabetic nephropathy to keep the threshold for target as 140/90. But I'm mentioning page number of Harrison just for your reference here. I just memorized it right before the lecture. That is less than 130/80 millimeters of mercury. I mean, you can go to this page number. This is the value that is given. So I don't dispute the fact that lots of time in hypertension, those mathematical values are the ones which cause trouble. But I have tried to give you the bigger picture by telling you that it is not the mathematical value that matters. It is the concomitant damage that is present which will decide what kind of intervention would you be doing in a patient. Like suppose a person is having a malignant hypertension and the BP spike is very much there. So I will have to lower the BP of this patient. So by how much? So he is saying lower the mean arterial pressure in a range of about 20 to 25%, not more than 25% decrease in the value of mean arterial pressure. Why not? Because I said a formula verbally. I'm just writing it here before you. Cerebral perfusion pressure is a difference of MAP minus ICP. If you lower the MAP, you lower the cerebral perfusion pressure, so you can actually worsen the ischemia in the brain. So the guidelines are, in any patient with gross elevations of blood pressure, the MAP should be lowered by a maximum of 25%. The word is maximum of 25% over a duration of 2 hours. Suppose what happens, the query of lot of students is, sir, what if we exceed this? If you will exceed this, if you exceed this mathematical value, then not only there will be worsening of CNS perfusion, but even exceeding this value can contribute to compromise of the coronary circulation. It can contribute to renal ischemia. So multi-organ damage can be seen. And specifically, if he asks about end-stage renal disease, though I've spoken about it earlier, we can definitely be using alpha blockers in these patients, considering the fact that there might be a substantial amount of peripheral edema in the patient and CCB cannot be used. And if he asks you about end-stage renal disease, then what drug would be recommended in these patients? Then we can be using alpha blocker, or we can be using calcium channel blockers also. As I've explained to you, if there's a lot of peripheral edema in the body, then instead of calcium channel blocker, even alpha blocker can be used. For patients of CKD, if they are in initial grades, grade 1, 2, 3, I can use ACE inhibitor, I can use ARB, either of the two. We never combine A with A because that can contribute to dangerous hyperkalemia. To this, we can add calcium channel blocker. To this, we can even add thiazide group of diuretics. If he specifies that the estimated glomerular filtration rate in a CKD patient is less than 30 ml per minute, and he says what drug would be recommended for these patients to help in control of blood pressure, we can be using metazolone. But if he specifies the word end-stage renal disease, then there are two possibilities which can be used, which I've already explained. This is the third time that I'm highlighting this because this has been asked in the NEET exam, recently concluded one. We can be using either of the two with obviously a watch for the side effect of edema that can occur with calcium channel blockers. So in this discussion, guys, what I've done is I've tried to justify the various cutoffs. I have tried to explain rational usage of drugs for management of these patients of hypertension, and I agree to the fact that lots of times the numbers that I'll be saying will contribute to a lot of distress when you read it the first time. Sir, there are so many cutoffs that you mentioned. You have given 2 references, but then because they are given like this in the textbook, it is my duty to inform you that this is the kind of information domain that you need to remember, because after all, knowledge is power. So the wider base that you have, because the easier thing for me would have been I could have told you, okay, remember this one single cutoff. But then the point is, in the exam, he can be using multiple sources and he can be coming up with varied kind of questions. Like for example, he spoke about hypertension in end-stage renal disease patient. I mean, this is something which is not even given in Harrison. This is given in, I would say, Braunwald, or this is given in current medical diagnosis and treatment. So you can understand, because he has asked something which is not given routinely. I have tried to make this discussion as vast as possible and try to incorporate as many guidelines as possible here. So thank you so much for your patience and hearing me out.